All right, good morning. Let's get started. Today I want to introduce Dr. Sarah Oberste and Dr. Jeffrey Graham. Dr. Oberste went to OSU Medical School, and she graduated as well as she completed her internal medicine residency at OSU Medical Center. Dr. Graham went to Touro University in Nevada, and he completed his internal medicine residency at Freeman Health System. They are both now GI fellows, and they're graduating December 31st. So let's welcome Dr. Oberste and Dr. Graham.
All right, can you guys hear me? Sort of, good? Okay. Well, we kind of wanted to pick something that we get asked about quite often. We used to do a lot of this here. We still do some of it. Dr. Hunt does come over and do EUS with some Cyst guidance here. So we'll go ahead and start. So there's different types of pancreatic cysts. One of the first things I always get is you guys call and say there's a pancreatic cyst. Well, what kind is it? What does it look like? What are the characteristics on the CTs? What are you seeing? What's the patient's past medical history? All this stuff is very, very important to us when you call us to give us a consult for this kind of thing. So it's divided pathologically into inflammatory fluid collections, non-neoplastic pancreatic cysts, and PCNs is what we see a lot of. And it's usually an incidental finding. As you know, you're looking for something totally different. You're like, oh, well, great. Now I got to address this now. And so when you see this, you just have to really start thinking about the patient's history and what the characteristics are. PCNs account for about 50% of all pancreatic cysts that you find. So inflammatory fluid collections, you can break that down a little bit more, is they're not true epithelial cysts. They're local complications of acute pancreatitis. So within 4 weeks, you usually see this, like pancreatic fluid collection outside the pancreas, or it can be inside. Now, in 2013, Atlanta classification came out with the revised kind of terminology for pancreatic cysts. A lot of you still call them pseudocysts, which is fine, but they've really included that into what type of fluid collection and the characteristics of that fluid collection. So inflammatory fluid collections now include acute peripancreatic fluid collections, pseudocysts, acute necrotic collections, and walled-off pancreatic necrosis. So, and then the setting, this is always usually in the setting of an acute interstitial pancreatitis within the 4 weeks of onset of pancreatitis. Typically, it's extrapancreatic with no definable wall. The fluid contains no solid material, no loculation, and no necrosis present. Pseudocysts is what we usually hear the terminology as, is a mature fluid collection outside the pancreas. Develops within 4 weeks after acute pancreatitis, and it does have a well-defined wall, but still no solid material or necrosis present. And it may also develop following trauma to that area. Acute necrotic collections, a setting of necrotizing pancreatitis adjacent to or involving the pancreas. It doesn't have a wall, and it may contain solid or liquid. Like I can't see it there. Walled-off pancreatic necrosis, mature encapsulated collection of pancreatic necrosis, contains liquid or solid elements with or without loculation. Develops 4 weeks after acute pancreatitis. Now, the non-neoplastic cysts, or true cysts, are very rare. Few case reports on this. It's a benign epithelial cyst of the pancreas with cuboidal epithelial lining. And the nature is unclear when you start to research this. They have theories of why, but not really definite research on it. Retention cysts are small dilated pancreatic duct side branches due to obstruction from debris. Then you have mucinous, but it's a non-neoplastic cyst lined with mucin cells, but lack neoplastic features or ductal communication. Cystic tumors of the pancreas, relatively uncommon, less than 10% of pancreatic neoplasms. Mucinous cystic neoplasms, serous cystadenomas, and intraductal papillary mucinous neoplasms, or IPN is what we usually hear, comprise more than 80% of the primary cystic neoplasms of the pancreas. Differential diagnosis. The first goal always is to exclude a pancreatic pseudocyst because we want to determine, what the next step is. We need to decide what this cyst is, what it looks like, the characteristics, and then you can always go to the next step. So on pseudocysts, what you need to look for is the lack of an epithelial lining, collections of extravasated pancreatic secretions from a disrupted duct, secondary to inflammation or obstruction. Radiographic features favoring a pseudocyst over a cystic neoplasm. The pseudocyst will lack septate, loculations, solid components, or cyst wall calcifications. The pseudocyst fluid evaluation displays high levels of amylase, as kind of we all know. But always remember, just not that one test tells you it's a pseudocyst. If you get a high amylase, yes, that's really, you want to say, oh yeah, it's a pseudocyst. But there's also other things that you need to look at for this. Never rule out, PCNs or any of those things, because it's a lot of people do that and then it comes back later, 6 months later, that now it has, a solid component. Oh, now it's gotten bigger. Now it's greater than 3 centimeters, those things. So you need to just don't put all your eggs in one basket and say, oh, it's got a high amylase. That's what it is. Once a pseudocyst is ruled out, evaluation should focus on identifying tumors that require surgical resection due to actual or potential malignancies. Tumors with malignant potential include MCN, IPMN, solid pseudopapillary tumors, and cystic islet cell tumors. Serous cyst adenomas, in contrast, are almost universally benign. So diagnosis and imaging. CT or MRI of the abdomen with IV contrast enables tumor localization and sometimes discrimination between pseudocysts and cystic neoplasms. ERCP is useful for the diagnosis of IPMNs and allow biopsy samples by brushings. EUS allows detailed characterizations of the cyst wall, identifying fine structures such as septations or wall nodules or mural nodules. And additionally, EUS allows for FNA of the cyst contents for characterization. So here's kind of one of the things we also do to look at the ducts and things we'll kind of talk about later too is a lot of you, I don't know if you have been down there and we've done this procedure, spyglass is really one of the newest things out there that a lot of GIs do. And we can actually drive up into the common bile duct, left and right hepatic ducts. We can actually see the cystic duct. It's really, really neat. And me and Dr. Graham have been to a couple of CME trainings actually where we got to train with some of the guys that do this all the time. And so it's really neat to see these, and they have kind of a library of bile duct findings. And so when you see all that, it kind of puts it all together what you're looking for. But this is something that's really neat that we do here at CTC. We do it at CTCA, and we used to do it, we still do it here with Dr. Hunt with spyglass. So here's some of the characterizations. This is kind of an older slide, but I just wanted you to be able to compare. The viscosity is very low in pseudocysts, very high in more of the benign type of cysts. And you always want to get cytology. That's one of the biggest things that we'll get is we'll put a lot of the fluid in cytology. We'll want to get markers. And we'll want to look, when we do FNA for biopsy too, we'll want to look at the cytological features. What kind of cells are they, cuboidal, columnar? And we'll actually can see malignant cells in there, right there. We'll have pathology come in with us, and when we do aspirations, they'll actually put it on a slide right there and look for us, especially at Kids Treatment Center. They do it here too sometimes if they're available, and they'll actually tell us what's going on and what they see. So mucinous cystic neoplasms are the most frequent encountered cystic tumors of the pancreas, up to 45%. Most are thick-walled cysts with occasional septations filled with thick mucus or hemorrhagic material. They display a clinical and histological spectrum ranging from clearly benign to frankly malignant. Current pathological classification distinguishes between benign, borderline, or malignant. Tumors based on their maximal degree of dysplasia. So mostly occur in us females. It's confined usually to the distal pancreas, so body or tail, and it's usually between 50 and 70-year-old women. Surgical resection is advocated for all MCNs due to the inherent potential for malignancy. So what we can do is distal pancreatectomy with or without splenectomy. And then here are, you can kind of see right next to the tail. So serous cyst adenomas, second most common cystic tumor of the pancreas. Clinical presentations similar to MCNs occur mostly in women. As women, we get a lot of this apparently. Mean age is 62. Most occur in the body or tail also. Macroscopically, they are well circumscribed neoplasms that on cross-section, so numerous tiny cysts separated by delicate fibrous septa, giving them that honeycomb appearance you'll see. And you can see this really well on EUS. The cystic fluid analysis characteristically reveals a low viscosity, low CEA, and negative cytology. And so it kind of looks like if you think of polycystic kidney disease, and that's what it can be associated with. That's what the pancreas looks like, you can kind of see. Intraductal papillary mucinous neoplasm, IPMN, is what we see a lot at CTCA. Neoplasms within the main pancreatic duct showing mucin hypersecretion that often leads to duct dilation and chronic obstructive pancreatitis. Classified also by pathological, benign, borderline, or malignant based on histological characteristics. There are 5 histological types of IPMN. I don't know if you guys know that. They occur equally in men and women. Median age at diagnosis is usually around 65. And CT often demonstrates pancreatic duct dilation. On ERCP evaluation, you see this thick mucus, maybe seen extruding from the ampulla bladder, nearly pathognomonic for IPMN. I've seen this twice, actually 2 here, where we go in there and you have a very patulous ampulla and you just see all this goo just coming out of it. We call it fish mouth. And sure enough, she ended up having IPMN, main duct. So the treatment for this, obviously, is surgical resection. Usually involves the head or uncinate process. Some pictures there. See these little outpouchings. Solid pseudopapillary tumors account for less than 10% of the cystic tumors of the pancreas. Young women most frequently affected, most found in the body and the tail, can be large at presentation, 34% of patients having masses larger than 10 centimeters in diameter. Considered to have uncertain malignant potential. Complete resection is the treatment of choice, though. So then you also have acinar cell carcinoma. Presentation may be indistinguishable from ductal adenocarcinoma. The prognosis appears to be better than ductal adenocarcinoma, but still an aggressive malignancy. Then you have pancreatic lymphoma, less than 1 to 2%. Consider whenever a large mass is identified in the pancreas without biliary obstruction, pain, or weight loss. And also, so that one's treated a little different in combination of chemotherapy and radiation. So now what? So now let's say you've identified your cyst. Let's say it's a benign cyst. What do you do with it? When do you look at it next? When do you consult us and say, hey, I need you to do an EUS-FNA on this because of these characteristic findings that we found on CT or MRI? So let's see. So these are based off of the guidelines. There's not a lot of really definite studies out there saying which one's right or wrong, but these are guidelines. So if anything, you should base what you do off of them, and then you can kind of tailor them to what you think you should do next. So patients should have an understanding of the risks and benefits of the program. You need to explain to them the risks of what you see. Let them know what you're going to do to watch them and surveil them throughout the next 5 years pretty much. And when they're going to ask you immediately, because they're going to be very concerned about this cyst being malignant, when should I have surgery? That's usually the biggest thing is, when can I cut it out? Can I get rid of it? Can I get rid of it? They'll ask you that question a lot. So you need to kind of know what you need to do to get to this step. So pancreatic cyst less than 3 centimeters without solid component or dilated pancreatic duct. MRI surveillance in 1 year, then every 2 years for a total of 5 years. If there's no change in size or characteristics, you actually can stop surveillance after that point. Pancreatic cysts with 2 high-risk features, meaning the size is greater than 3 centimeters, the pancreatic duct is dilated greater than 10 millimeters, and there's presence of an associated solid component. Should be examined with EUS and FNA. So this is when you need to send to GI, when you realize that there's something else going on there. If it's greater than 3 centimeters, you have increased malignancy by 3 times. A solid component increases malignancy by 8 times. And so sometimes what we'll see when we go in, when we see something like this with these characteristics, we go in with EUS and we'll actually see a lot of sometimes mural nodules when you tell us there's a solid component. So a mural nodule does not have a definable wall, and it has isogenic or a hypoechoic to its surroundings, and so we can just see this kind of irregularity when we look at EUS. And so that's always concerning for us, and that's what we'll hit for FNA and FNA biopsies and core at that point. So no concerning findings on EUS and FNA. Let's say we did it, we didn't really see anything. Then you have to surveil them in 1 year and then every 2 years after that. Anytime there's a change in the size of the cyst greater than 3 centimeters or a solid component develops, AGA always recommends EUS and FNA. I would say if you have a cyst and you get an MRI and you see any changes, an increased dilated duct, it's getting bigger of any time. Anything like that, there's a solid component. Those are always increased risk for malignancy, and you need to consult us or send your patient to GI. And then we get a lot of when can surveillance stop. I've seen some cases where this patient's had this one tiny cyst that's like less than a centimeter, like in the tail, and it's been there for 5 years and it's unchanged, and I usually tell them it's nothing. If it's not changed in 5 years, then the chance of malignancy is very rare. But then, people don't like to say that when you quit watching something. So it's just up to you at that point. You could actually extend it out to every 2 to 3 years, watch it. But after 5 years, if you have a cyst that has not changed after the same person, you always want to try to get the same person to read your CTs, especially when you're looking at a certain something. For 5 years, then then I would say, okay, let's do it. I'd probably still say every 2-3 years, but the AGA does recommend that you could stop it. All right, and then Dr. Graham is going to talk to you about some of the stuff that we can do to help with these cysts and some of the procedures we do.
Okay, well, I'm here to talk about interventional EUS. So EUS came out in the early 90s. It really took off in the mid-2000s when technology and resolution of the EUS units got better. You're only as good as what you can see. And so back in the day, it was great. It was great for our forefathers to go ahead and start the movement, but it's going to explode in the near future. So for those of you, when I started residency in 2009, had no clue that EUS even existed. I came from a medical school where the GI program was going under huge malpractice issues. And so when I went to Freeman and Joplin, there was only one guy in town, and that town services about 500,000 people. And there was only one guy in that unit, in that region, that actually performed EUS, and he used an older model. Coming down here, we've been fortunate with the newer technologies to actually get really good resolution, and you can actually do beneficial procedures on people. What does this mean? If you can go down the GI tract, so go through the mouth, go down the esophagus, stomach, and the first part of the small intestine, any organ adjacent to that lumen, that intestinal lumen, can be accessed with EUS. What does that mean? Well, if there's something solid, you can stick a needle in it. That just really opens up your abilities to perform interventions that are proactive. You can get diagnosis, you can treat people, you can provide therapies. And so as Sarah was just discussing, if you see cysts, she discussed performing EUS. Back in the day, you would have to go to interventional radiology and get a needle through the skin. And sometimes that can be dangerous. You're going through, sometimes blindly going through blood vessels. And there's maybe some risks that you may not want to take. EUS has Doppler, and so you can see blood vessels. And so you can reasonably, safely perform these procedures without harm. So as I just discussed at length, I had already said all that. You don't want to do that. So anyway, come down the mouth. So anything around here, you can stick a needle in. Stick a needle in the liver, stick a needle. Oh, that's a kid. We don't do that. In Asian countries, if let's say you were you needed a cholecystectomy, but you were high risk surgically, you can run a needle and run a stent from the gallbladder into the small intestine and drain the gallbladder internally. That's done in Japan, maybe someday here. Of course, the pancreas, that's the topic of this discussion. Pancreas is all right there. So we have lots of fun stuff to do with the pancreas. So other things that you may not be too familiar with. Celiac plexus interventions. I'll talk a little more about that at length. Fiducial mark replacement that helps radiation oncologists with placing seeds in tumors. That way they can more rapidly and more effectively perform radiation therapies. We can inject chemotherapy. We can inject ethanol to ablate cysts. Or we can aspirate cysts and get biopsies. You can also do fine needle biopsy, and that's more of a pathological term about the gauge of the needle. But we generally call it FNA, tumor cysts. And we can also do EUS-guided biliary drainage. So let's say you do an ERCP, which is virtually the same procedure. You go in through the mouth. You get down to the first part of the small intestine. You see the ampulla. You run guide wire up towards the liver into the common bile duct and try to drain the liver. Well, sometimes that's unsuccessful because you may have a giant tumor right there at the ampulla, and you can't get in. With a strong interventional radiology department like we have here, IR is able to, especially if you have dilated ducts, able to stick the liver from the outside, from the skin edge, run a guide wire down the bile ducts and stick it into the intestine. And we can come in after that and fish that wire out and get access into the common bile duct. With EUS guidance, you can run your linear EUS scope down into the small intestine, see the bile ducts, stick a needle into that dilated bile duct, run your guide wire, and do your own rendezvous. So I'll talk about that a little later. So with CPN, so pain management guys and anesthesiology does blocks. If you have malignancy, pancreatic cancer, for instance, was where this was first studied. You can identify the celiac plexus, go down the esophagus, see where the celiac axis is, see where the celiac artery comes off the aorta, and inject that region with alcohol. Okay, that kills the celiac nerve plexus. That celiac plexus, all it does is send it wires up to the brain, say, there's something wrong here, I'm sick, I'm hurt. So if you ablate the nerve, kill it with alcohol, pure alcohol, 98%, moonshine, strong moonshine. You inject that, kill the nerve. That's helpful, and there's very little risk. Fortunately, you don't see a whole lot of complications with this. Sadly, these people are typically end stage, but there are discussions whether or not you should use a fenestrated needle. That's just a fancy word for a needle with a bunch of ports on the side, so you spread out the alcohol along the tract, or you can just use a regular needle and basically depot it into the nerve root itself. So what are the benefits? Well, people don't like to be on opioids. There's a lot of some people really like to be on opioids, but we'll talk about the people that do not. Opioids can alter your mind, obviously. You know that by now. And so when you alter their mind, your family member is not your family member anymore. So if you have end-stage pancreatic cancer, for instance, and you're doped up on morphine, you're not alert, you're not yourself, you don't want to eat, you're constipated, you're not the same person. And so if you can reduce or eliminate a patient's requirement for morphine just for quality of life, this is a reasonable opportunity to do so. For referrals for CPN, they need typical pancreatic type pain. So they do best with epigastric central boring to your back pain. If they have right lower quadrant pain, this isn't probably going to help. We can do it with low risk, but you think of your typical pancreatic pancreatitis pain that presents to the ER, that's your typical pancreatic cancer pain. So I like to talk about complications because everyone needs to know them. Interestingly, this can cause diarrhea. That's a systemic reaction. That is usually very well treated with Lomotil. Bleeding, I have never seen happen. Fortunately, we have Doppler guidance, so you can see where major blood vessels are. If you see a major blood vessel, you don't stick a needle in it. That's a pretty good rule. And then paradoxical pain, that's hard to prove. You don't know if it's a complication of CPN or just what's already there. But in the studies, they talked about paradoxical pain, but in the clinical world, you just don't think you did it very well, a very effective block. And some people it doesn't work very well with, and can't explain why. So EUS-guided cyst ablation, this is disappearing. This was for your patients that had pancreatic cysts that were not really good surgical candidates. So what is it? You go ahead and you find your cyst. So as was already discussed, you have your high-risk cyst qualities. So I'm going to skip that slide. And you inject those cysts with alcohol. Okay. You can also use chemotherapy if you think they're malignant. There was a study with paclitaxel injecting with chemotherapy. I don't see that happening anymore. There's a lot of risks to injecting a cyst with alcohol. The cyst can spill, leak, and then you have the contents of the cyst. You can end up like this young lady. I'm sure you've met one of her before. You can develop pancreatitis and feel pretty crummy. So this is new technology, probably out. This hit the market pretty freely this year. But this is a Boston Scientific product, and it's called the Axius stent. And what it is, it looks like a spindle, and you identify your cyst on EUS, big pool of fluid, okay? You stick a needle in it, you run a guide wire into that cyst. So now you have access from the GI lumen into the cyst. Using the hot Axios, you plug it up to electricity, you run this device, this collapsed stent over the guide wire, and using electricity, you can basically burn yourself into that cyst. Okay? So now you have the internal side of the stent into the cyst. You deploy the distal spindle or hub into the cyst. You pull back on your device, and you now deploy the internal, like the GI lumen side of the spindle. Now you have a conduit from the GI lumen into the cyst. Okay? So these people shouldn't need to go to surgery. You can drain the cyst. You have access to the cyst. Very important. Very easy with good technology. With the resolution out there, this is getting fun because typically the people that develop pancreatic pseudocysts are not the most reliable population. And if you can effectively treat them when they show up, you are getting ahead of the game. And there are cost implications down the road. Very good. So as I discussed earlier, IR has been very helpful in the past with providing access to the people that we could not get into doing ERCP. So you go do your ERCP, for whatever reason it is, you cannot cannulate the ampulla, you cannot get access to the liver. So in the event that there's either a stone down at the ampulla, a stricture of unknown origin, may it be malignant. What else? Oh, you get gastric outlet. Let's say you have a tumor in the gastric outlet and you can't even get into the small intestine. Let's say they had a Roux en Y. So you can go ahead and use EUS guidance and provide access to the common bile duct, common hepatic duct. So you identify the ducts on EUS, you run your needle into the ducts, you fish a wire through, and you can drain the biliary system. There are multiple ways to do that. And they've done studies, of course, everyone's done a study, but you can either drain the biliary system into the stomach, if that's where you can easily see the duct. You can drain it into the small intestine, if that's where your access is, or you can fish a wire through the ampulla and go back and do your ERCP, fishing that guide wire that's now sticking out of the ampulla, going backwards. I guess it still is retrograde, but you anterior-gradely fish the wire down through EUS. You switch out to your ERCP scope, and you perform your ERCP over the guide wire. But of course, if you're doing a rendezvous, you have to have access to the papilla. So think about that, or we'll think about it for you. I already discussed all this, and you probably don't really want to know about the stats, but it is it's helpful. Let's see, I nailed that. Oh, yeah. So the benefits of GI doing EUS-guided biliary drainage versus interventional radiology. Interventional radiology, they identify the ducts, and they're able to drain the biliary system with external tubes. So the patient, it's very fortunate for the patient, they get to be decompressed in the event that you cannot drain internally. The problems are you have a tube. So that's wound care, or there are direct costs to that. Inconvenience, wounds, the tubes get dislodged, and it's in an ER visit, 11 o'clock on a Friday night. So and here's a picture of what these tubes look like. So it's not necessarily fashionable. And so if you're able to provide internal drainage, you've increased their quality of life. So it's essentially, you can do an anterior grade ERCP, I guess it's an EACP. But the benefits of this include internal drainage. You don't risk pancreatitis because you're not messing around the pancreatic duct, and because you're not going across the PD right at the ampulla. So that was rapid. I probably went faster than I needed to. But do you have any questions? I know you do. Then don't call. You got it all. Please call, actually, please call.
If you guys ever have questions, you guys most of you all have our cell phone, which is text, we'd be happy to answer any questions before you go into the other stuff.
You guys are ahead of me. I had no idea what any of this was when I was at your level, so good luck.